All right, so thank you for asking me to speak about a topic that I'm quite passionate about. And so our objectives of my talk really, we're going to do a brief overview of lymphoma. We're going to talk about watch and wait and why we use that strategy, as well as the emotional impact of using this strategy. And then lastly, we're going to talk about why people need treatment. And so first of all, when somebody's been diagnosed with lymphoma and you're told you don't need treatment, it really kind of goes against what we've kind of been taught in the media, you know, at your family doctor's office. Usually there's such a focus on screening and the importance of early cancer detection and treatment that it's very hard to wrap your head around the fact that have cancer and we're actually doing nothing about it, which is a perfectly good strategy, but not what people are expecting. The other component that we're going to talk about is that when people have completed treatment, we're back to using a watch and wait or a surveillance type approach.
All right, I'm in.
So my hope is we have a better understanding of lymphoma, then we'll understand why we use this type of approach. And so I'm just going to start out with the basics of what is the lymph system. And so the lymph system is made up of branches of tubes that really go throughout the body, and they really kind of are parallel to any blood vessels. And they contain lymphocytes. And lymphocytes is a really important word to know in lymphomas. There's B lymphocytes, there's T lymphocytes. Also, the lymph system involves parts of the organs as well. So your tonsils, your liver, your spleen, and the bone marrow where blood is made, or I call the factory of blood production. And so your body's lymphatic system is your immune system and helps protect against infection and diseases. And so lymphoma is a cancer of the lymph system or your immune system. So I bring up this next picture of a lymph node. And the reason why I bring this picture up is when a lymphoma is diagnosed, it's really important under the microscope to know what type of lymphoma one has. And so you can see in this picture, there's in the left-hand corner, the yellow dot, there's a lymphoid follicle. There's also a terminology of germinal center or marginal sinus. These are all parts of a lymph node. And when lymphoma starts to become active, it's really about what part of the lymph node has become active with cancer cells or the lymphoma. And that really helps to decide, well, what type of lymphoma we're dealing with. There's other parts to it as well. For example, there's molecular testing and proteins that are attached to the lymphocytes. But really, just knowing the anatomy of a lymph node helps determine what type of lymphoma people have. So the next picture here, I just really wanted people to have a sense that lymph nodes are everywhere in the body. We can feel them in our neck and by the collarbone and under the arms and in the groin area, but there's lots of lymph nodes that are deep inside the body that we can't feel. So lymphoma, use it as an umbrella term. So there's different types of lymphoma, and when we talk about lymphomas, it's either Hodgkin's or non-Hodgkin's lymphoma. And then under the non-Hodgkin's piece, you can see other diseases like the leukemias, the chronic leukemias, who actually fall under the non-Hodgkin's lymphoma. And so we know nowadays that there's over 60 different types of lymphomas, and so it's really important to know well, what type does one have? So the classification of lymphomas is organized by the World Health Organization. And so we're going to talk about just briefly the Hodgkin's lymphoma and then non-Hodgkin's. And I just want people to have an understanding of how many different types there are. And so in the Hodgkin's category, there's really 5 types of lymphomas. One out of the 5 is considered more of a low grade, and we use a watch and wait approach with this type of Hodgkin's lymphoma. So it's the nodular lymphocyte predominant Hodgkin's lymphoma. And so people aren't really used to thinking, oh, Hodgkin's, you can watch and wait. That's not kind of what most people understand about Hodgkin's lymphoma. Moving on to non-Hodgkin's lymphoma, as I said with the anatomy of the lymph node, there's the B cell and then there's the T cell. And so this slide is very busy, but it gives you an understanding of how many different types of lymphomas are out there. And this is just in the B cell category. And this next slide gives you just a snapshot of how many different types of T cell lymphomas there are. So when you look at watch and wait, we're really looking at the categories that are chronic, long-term, indolent, not active, all different terms for the same wording. And so in the B category and the T category, there's different types. And so I've just listed a few: follicular lymphomas, Waldenstrom, macroglobulinemia, the marginal zone, small lymphocytic lymphoma, which is really what I say a cousin to chronic lymphocytic leukemia. With this chronic lymphocytic leukemia, it's really, you find the lymphocytes in the blood, whereas once the lymphocytes are active in the lymph nodes, then we interchange and we use the word small lymphocytic lymphoma. Really means the same thing. And then there's other types of indolent non-Hodgkin's lymphoma that we, again, would use more of a watch and wait approach. And so this is where I think it's really important to know what type of lymphoma one has, because, you know, what I see and hear in clinics is somebody will say to me, well, my neighbor has lymphoma and they had a different treatment than I'm having. And when I ask the question, well, what type of lymphoma? The answer is, well, oh, I don't know. And so, you know, you really need to compare apples to apples and oranges to oranges when you're comparing stories, because one type of lymphoma, the treatment may be completely different than what another type of lymphoma warrants. And you really need to have an understanding of what your lymphoma care needs are. So the next step that I want to go through and is how do we come about a diagnosis of lymphoma? And one's health history is very important. We look at, well, how is someone feeling? That is an important question to ask, giving a history. We look for lumps and bumps. Are people having any symptoms? So shortness of breath, abdominal pains. And then in the lymphoma world, we're very interested in B symptoms. And B symptoms, fevers, so a fever of 38.0 or higher, drenching night sweats. These are sweats where people wake up soaked, needing to change their bedding or their clothing. Most people say they need to jump in the shower afterwards because they just feel drenched. And weight loss. And so in general, most people have to really work hard to lose weight. For weight to just drop off for no reason is really not natural. And so when we talk about B symptoms, it's the collection of the three together. Then we move on to investigation. And so with the investigation piece, there's the physical exam where we can feel lymph nodes in the neck, in the clavicular area or the collarbone area, in the groin region. Also, we're listening for people's respiration. So are they having a good air entry? We're feeling the abdomen, looking to see if the liver and the spleen may be enlarged. With lymphoma, it's 100% we need a biopsy. And there's many different ways to go about having a biopsy. Our preference is usually an excisional biopsy, so we get a piece of the lymph node, but sometimes that's not possible, and so there are 3 different ways. So FNA means a fine needle aspiration, where a needle's into the lymph node. There may be a little piece taken, or the whole piece is taken. Also, from a laboratory standpoint, we look at blood work. So we really want to know, how are you making your blood? Lymphoma can be active in the bone marrow, which is the factory where the blood is made. And so we want to know, how are you making your blood? There's also a few blood tests that we look at. And how I describe it is a blood test looking at cells that are dividing very quickly. And they're really non-specific. So for example, if you bumped your leg, you were working out very hard. Sometimes people who have some heart pain, there's markers that go up in the body. So we know that this marker can go up for many reasons, but we also can see the markers going up with lymphoma. So LDH is a marker in non-Hodgkin's lymphoma, and ESR is another marker for Hodgkin's lymphoma. And so they're part of the standard blood tests that we look at. Some people need a bone marrow biopsy, some people do not. We also look at various pictures, so imaging, so chest x-rays, ultrasounds, CAT scans, gallium scans, PET scan. And it really depends on what type of lymphoma you have and what type of testing needs to go with that. Sometimes lymphoma will be part of the central nervous system, and so sometimes people will need a lumbar puncture, really taking fluid from the cerebral spinal fluid to see if there's any lymphoma cells that are present there. So lots of tests need to go in to diagnose lymphoma, and then the next step once you have all your test results is deciding what stage is the lymphoma in. So stage is very important, and in the blood world, so lymphoma, leukemia, our stages mean something completely different than in what I call the solid tumor world. So in the solid tumor world, when people are diagnosed with a stage 4 type of cancer, it means it's spread from the original site. So for example, take a colon cancer, and that colon cancer has, say, spread to the liver. When we're talking about blood cancers, so lymphoma, leukemia, the stages really mean where are the lymphocytes, or where is the lymphoma active. So stage 1 means really isolated to one area. Stage 2 meaning there's 2 or more lymph node groups that are affected, but on the same side of the diaphragm. So your diaphragm is at the middle of your body. Stage 3 means that you have lymph nodes above and below the diaphragm. And then stage 4 means that it can be in other parts of your body. For example, your liver, your bone marrow. And so when people use the word stage 4, it does not mean the same thing as metastatic disease. We actually never use the word or the term metastatic disease in lymphomas and leukemias. The other piece of the staging that comes into play is, and we use A and B. And so A means that you have no B symptoms. B means that somebody has had B symptoms. And the B symptoms, again, are fevers, drenching night sweats, and unexplained weight loss. We also sometimes will tag an E to the end of a diagnosis. And E means that there's parts of the body other than the lymph nodes that are involved. And so sometimes people will have their lung involved. Sometimes, sinuses are involved. It all depends. And so that's where you may have a diagnosis, say a stage 2BE or a stage, 4AE. So it all really just tells you where the lymphoma is at. So once all this information's together, you know where the disease is, then the question comes, well, what is the right treatment? And so the right treatment may very well be, because this is with the chronic diseases, the chronic type of lymphomas, watch and wait might be the best strategy. If people feel well, have small lymph nodes, their blood is very good, then what we know is that giving people treatment when they're feeling well shows no survival advantage compared to using a watch and wait approach. Now, in the chronic types of lymphomas, well, who actually needs to start treatment? And so there's two separate criteria that are available. One's called the GELF criteria, which is Group d'études de lymphoma folliculaires, which is French, and this is not my accent whatsoever. But so you can see here in the GELF criteria, if people have 3 nodes that are greater than 3 centimeters in 3 different areas, that may be someone who needs to start treatment. If a lymph node is greater than 7 centimeters, again, that might be a reason. B symptoms may be a reason. Compression syndrome. So that means you have a lymph node that may be pushing on a kidney or pushing on the liver and causing compression of that organ. That would be definitely a reason to start. Cytopenias, which means that the blood is low. It could be your hemoglobin, it could be your white count, it could be the platelet count. If they're low because the bone marrow has infiltration of lymphoma, what that means is there's no space in the bone marrow for normal healthy cells to grow, and the bone marrow becomes crowded and cannot make the appropriate cells. So that would definitely be a reason why people would start treatment. People also can have enlarged spleens. Now, a small enlarged spleen that people are having no symptoms with whatsoever, we just watch that. But if the spleen becomes large, where it's actually below the belly button or across the belly button, and people are having issues regarding decreased appetite or pain with eating or pain in their abdomen, that would be a reason to start treatment. And then if there was a collection of fluid, say in the belly or in the lungs, that again would be another reason to start treatment. So we have certain criteria that's set out to say, if you have a low-grade lymphoma and you have some of these criterias, then we need to get on and start treatment. And so with using the watch and wait approach, we're really talking about a slow growing form of lymphoma where people are feeling well, no troublesome symptoms from the lymphoma. People may have some small lymph nodes, but really not causing any problems. They may be changing, but they're not doubling or tripling in size. People who have blood tests that are acceptable, and no one's major organs, so lungs, kidneys, liver, are affected. So this is a very good strategy to use if people are having no symptoms and there's no compromise on the body. What we know about these chronic type of lymphomas, that they progress slowly, allowing treatment for many people to be delayed for months or even years. Yeah. In 2012, it is still considered the best long-term strategy. We know that if we give people chemotherapy when they're well, chemotherapy comes with side effects, and some side effects could potentially be permanent. We also know that the immune system is very smart, and when we give chemotherapy to people who are healthy, your immune system may remember these drugs or the combination of drugs given, and what can happen is people can actually have a resistance to chemotherapy in the lymphoma cells. And so when people truly have symptoms and are sick from the lymphoma, the chemotherapy may not work. The first line of chemotherapy or second line chemotherapy may not work as well. And so then we're moving to chemotherapy protocols that are much more aggressive. And so the next slide here, there were some studies and statistics that have come out. They're pretty old, looking at clinical trials comparing patients who had no treatment versus patients who had treatment up front when they're feeling well. These were done about 25 to 30 years ago. And really, the outcome was the same. People live the same amount of time, whether they have treatment when they're well versus saving treatment for when people are unwell. The question, though, that comes up now is, what about the Rituxan era? We have new agents that are available, the monoclonal agents, and so should we be using these monoclonal agents when people are feeling well to maybe delay a reoccurrence? And currently, we don't have any data to support starting treatment up front. There was no difference of overall survival at 5 years, but I think this is an area that's very interesting, and certainly if any changes come about with new drugs or management, we, Lymphoma Canada, will be the first to know and adopt different strategies for sure. With these indolent, low-grade, chronic type of lymphomas, people can go through periods of feeling very well. Then people have some symptoms, treatment, and you're in a bit of a cycle of, well, treatment, you're then in a remission, relapse, and so people can become in this chronic type of loop. What we need to remember is that presence of disease does not alone mean people need treatment. Really, people who are well need lots of reassurance and education to say, this is okay, this is the right way to treat lymphomas, an indolent lymphoma, and this is the standard of care. And so many emotions are associated with a watch and wait approach. People can have anxiety, worry, surprised, they're angry. They could be happy to be doing nothing or fearful. And what I want to come across is that these are all normal responses. Fearful that, one doesn't know what the next steps could be. What does the future hold for me? How long am I going to be well for? How long, am I waiting for? And so this is all normal. And one hopes that every day goes by and there's less, there's more days of feeling well, that the emotions settle down. The point I want to make is that, your healthcare team is watching closely alongside with you. And so some people will find it hard waiting until their illness flares up without having treatment. And if this is you, remember you're not alone. Try remembering that having treatment could mean having to cope with side effects for really little benefit in the long term. Use this time to learn more about your own lymphoma, having a better understanding of the disease and how it may affect one. Helps people feel more prepared. Finding out what possible treatments may help people be informed when choices for a treatment comes. This approach doesn't suit everyone, but if you think it might make you more anxious, it's equally fine to not be researching and looking up information as well. It's really about how people cope and what works for themselves. This slide here, I really just put this slide up here to let people know that you're not alone. So when you look at the non-Hodgkin's lymphoma subtypes, the follicular lymphoma, which is low grade, the small lymphocytic, which falls into low grade, the marginal zone, these are all percentage of non-Hodgkin's subtypes. And so knowing that you're not alone, that other people are using the same approach, and it is a very good approach. My next title here is Watch and Worry. And I hear this quite a bit, that people are worried about what the future holds. There's anxiety of, well, what will this look like if I develop symptoms? And so one's sense of security or control in life is challenged, raising concerns about your ability to care for yourself, your home, your family, and work. And so some people will attempt to cope by regularly checking their physical health. And so checking lymph nodes every single day, and become so preoccupied with the health and checking in with themselves that there's preoccupied that you're really not enjoying life. Some people will seek additional reassurance and support, including complementary and alternative therapies. And I do think that there's a good balance with complementary and alternative therapies. I do think it's important, though, to be informed. And so lymphoma is a cancer of the immune system. And when people give lots of advice, take this tablet, take this vitamin, it's important to be informed. And so if somebody's giving you something that you're not sure about, you can always chat with your local pharmacist. You would let your pharmacist know that you have a history of lymphoma, and you can, give them the herbal remedy or the vitamin and say, is this fine for me to take? The pharmacist may say, yes, absolutely fine. They check a database. Or they may say, well, there's a couple studies here and there, and then you make an informed decision of if you'd like to try this. So regarding anxiety and worry, this will fluctuate over time and will heighten when there's suspicious symptoms requiring examination. And there can be external triggers such as family, friends, other practitioners that can increase one's worry. So for example, when you have a type of indolent type of lymphoma, you really need to be sometimes the one that educates other people about yourself. So for example, I had one patient who, went to see her dentist, and the dentist said, "Oh, you have a lymph node. You must go see the center." And so that caused worry, and coming back to the center and reassurance to say, "Yes, we know you have a lymph node. It's okay. This is your strategy." So some people, don't know a lot about lymphomas, and so knowing as much as you can about your own type of lymphoma and when to call in is very important. And you may be doing a lot of education as well to other practitioners. One of the quotes that I read, and it's really stuck with me, is that worry does nothing but steal your joy and keeps you very busy doing nothing. And when we're using this watch and worry approach, this is really one's time to be healthy. So well, it's time to enjoy one's life. So some people may get caught in a cycle of worry, continue to seek reassurance from other sources. And so it's important to have, great resources, great support groups, and really knowing that when you're chatting with other people that, you're really talking apples to apples and oranges to oranges so that it doesn't, increase the cycle of worrying. And so next we're going to move on to Alyssa Burkus. She's online and she's going to share her story with you.
Great. Thanks, Marg. Hope everybody can hear me okay. I posted a little note. I'll keep an eye on the chat. If you have questions for me throughout my piece here, just let me know. And Tanya's going to be advancing the slides, so that'll be interesting as we try to stay on track. As we go to the next slide, you'll see Marg and I used some similar language about watch and worry and some other pieces, but we developed our slides separately, so I just find it interesting the number of places where we overlap. So I use this visual in many of my talks because for me it really kind of highlights how I felt when I was first diagnosed. No one knew what lymphoma was. No one knew if it was a cancer, and I was young when I was first diagnosed, and so for many of my friends, this was the first time that anyone in our circle had really had anything big happen, and so didn't really know how to support me. Versus when other people diagnosed with more familiar illnesses, there's a little bit more support that's available. So if we go to the next slide, I just want to describe a little bit about myself, and Tanya, just feel free to pop some of those boxes in there. I was 31 when I was diagnosed. I was a newlywed. It was a time when we were looking to start a family, and so getting my health checked out, I really felt fine. The only thing that I had was a small, this will sound familiar to many of you, pea-sized lump on my neck that my previous family doctor had assured me 18 months before was nothing, but I brought it up to my new family doctor, and he actually said, I think we should probably pursue this. And it wasn't until I had a biopsy and, waited for those results that I had heard back from the surgeon that they were confirming that it was lymphoma, which was a complete shock to me. It was several months before we knew what subtype, and so they suspected, given how long I'd had the small lump, that it was indolent. It took a couple of different opinions until I had follicular lymphoma confirmed. And, being told that we were going to start with watch and wait, I was at a major center with a great doc, and even still, the idea of watch and wait was just so difficult for me to really handle. I like to think of myself as proactive and well-informed, and it just was a complete disconnect to everything that I had ever heard about cancer. And I'll talk a little bit on the next slide about some of the challenges. But when I was, after my watch and wait period, just to share with you some of the additional history, I did have CBP. I saw the question from Margot. We'll get Marg to answer it at the end, but my understanding is there really isn't any standard time to treatment for how long people are on watch and wait. In my case, it was 8 months. You've clearly gone much longer than that. I started to have symptoms that, really significant fatigue, and the size of some of the masses that I had was what ultimately determined my start of treatment. Hearing, again, Marg talk about certain things has made me realize just how long I've been living with this disease. Rituxan was not available to me when I started treatment. I had CBP alone. And we were talking about lymphoma as sort of 30-plus different types of diseases. And now hearing, over 40, over 50, I think Mark said over 60 different types. We're continuing over the years to really understand this disease in a much more narrow and specific fashion that I think ultimately is helping with treatment decisions and different paths, which is great. So I was originally given a 10-year prognosis. I was told that was on average how long people lived with my kind of lymphoma. I know many people who have lived much, much longer than that. And I myself, I'm almost at the 15-year mark for my diagnosis, which is amazing. And I just share that post chemo, went on to have 2 kids. I'm a business owner, which even in itself, making decision to start a business and outside of sort of corporate benefit plans and that sort of thing are some of the things that have been challenges. But overall, really have moved forward and built my life despite this disease. So if we go to the next slide, the easiest way that I thought to share some of the challenges that I struggled with was to talk in terms of either things that I heard in that first window of watch and wait. And by the way, I consider myself to be in somewhat of a watch and wait mode right now. I'm 6 years post-Rituxan at this point, and have not had any treatment in those 6 years. And so, I would consider my disease to be stable, and, it's really uncertain when I might need treatment again. But we keep an eye on it. But I'm describing here the watch and wait, that initial watch and wait time period, which was much more anxiety-filled and much more difficult for me to get my head around. So I'm using quotes that either were things that people said to me directly or thoughts that I had in my head that I was saying to myself, and sometimes, both. The first one, and some of you may have heard that as well, what do you mean you're stage 4 and you're not getting treatment? Does this mean you're terminal? Like, are you telling me there's no other options? And, I can remember the first time that I heard that, and it was just knocked me sideways. And as Mark touched on, my understanding and the research that I've done about lymphoma over the years is that staging does not have a bearing on prognosis. We really talk about just helping to identify where it is in the body. In my case, I had bone marrow involvement, that lovely bone marrow biopsy that some of you will wince just hearing the words. I still do. And so bone marrow involvement immediately put me right to stage 4, even though I didn't have any of the B symptoms at that point in time. And so, trying to wrap my head around being stage 4, not having treatment, but knowing and ultimately coming to terms with the fact that that was absolutely the best course of treatment. People would say, and Marg used almost a similar story, oh, I've heard of lymphoma, I know, somebody who died of that, which is awesome to hear that. It's just great. And, clearly we know, sadly, that there are people who lose their life to lymphoma. And, but with the many, many different types of lymphoma that are out there, there's so many different types of treatment and prognosis and options, and even the age and other health factors that are a factor for people when they're diagnosed all play into that. So give me a couple of other ones, please, Tanya. The early detection is a classic, and Marg touched on that already. I've never heard of not treating cancer. Shouldn't you get a second opinion? Really, very strong opinions from people who definitely meant well, but not understanding at all what was happening. Are you afraid to tell me what's really happening? I heard that from a family in particular. And people very close to me who were worried that I was protecting them from, potentially, some really serious treatment that I was going through that I didn't want to tell them about. They were Googling and seeing some really extreme stories or things about bone marrow transplants and wondering if perhaps I was just really kind of keeping them from bad news if I wasn't willing to talk about the treatment that I was having. And then the last one, really touched a nerve about, well, what do you mean you don't know how long until you're going to be treated? You really should take better control of your health care and really advocate more strongly. Like, that shouldn't be acceptable to you. Why are you, willing to accept that you're not having any treatment? And it's very difficult, and I think, and certainly as Marg talked about, educating yourself about exactly why, understanding that it is appropriate for your kind of lymphoma, that it is very common, that it is often a typical first step to watch and wait, and here's what we're looking for. In some cases, people actually they describe watch and wait as a form of treatment. The way I'm being treated is to follow my disease very closely. I'm having, 3-month checkups or 4-month checkups where they're doing these 5 things. We're monitoring for these other symptoms that may appear. I'm doing these other active things, are all under the watch and wait treatment plan that's been given to me at this time. And that wasn't language that I had or thought of at the time, but certainly if I were to go back and do it differently, I think that's how I would phrase it to people, that this is a treatment course that we're pursuing. So the next one on the next slide is just some ideas for ways that I coped during this initially 8-month time period, and many of these things I use today. So focusing on things that I could control. I would have trouble controlling my emotions. I didn't know at what point in time the watch and wait would end, but I did make a decision. I didn't always stick to it, but trying to stay healthy, continuing to exercise. I took up yoga during this time. There was also a meditation workshop that I took, and these were all things that helped me feel that I was making a proactive and very definitive active choice to keep my disease stabilized. I connected with the cancer community. I will say, as it says on that slide, I struggled initially with going to places like Wellspring and Lymphoma Canada because I didn't feel like a real cancer patient. To me, the person going through treatment with no hair was really the legitimate profile that I felt was only appropriate. How could I avail myself of free yoga at Wellspring for cancer patients and their supporters if I wasn't going through treatment yet? How could I take up a spot for a quote-unquote real cancer patient? And what I learned is that they really already recognize the full spectrum of patient stages, of where people are at in living with the disease, post-chemo. There's services that are available during watch and wait. There's, I joined a lymphoma support group ultimately for a period of time. And part of what that did was also help educate me about what was coming. I began to really look at those 8 months. I mean, at the time, again, I didn't know how long it was going to be, but I felt, a little suspended in time, and decided to use it to help me really understand the disease, what was happening. I took my detailed CAT scan report, because we didn't have PET scans available in those days. I feel like a grandmother telling you these stories back in the day. But I took my CAT scan or CT report to a friend of mine who'd done a lot of physiology in university, and she walked me through all the different places where masses had been detected. Okay, that's, in between your rib cage, and that's, around your liver, and, she took me through step by step, and I really understood my report. And, that was really a luxury for cancer patients, to have that kind of time to really process and understand. I know a lot of other people who have a crisis diagnosis of a spine tumor or a mediastinal chest or heart implications, where treatment is started right away. You're making rapid fire decisions. I actually was able to educate myself about lymphoma, and also understand what the treatment options that would be presented to me once watch and wait came to an end, which is ultimately what happened. We were given 3 options for treatment and needed to make a decision. And so it was much easier for me to do that, because I really felt well equipped from the time that I had had to wrap my head around it. So if we go to the next slide, there's just a couple more. The return to watch and wait, just a reminder that, there are these different phases. We go back and forth from being actively treated with drugs and other protocols to, for people like myself with follicular and other indolent forms, to being back on watch and wait. If we go to the last slide, just wanted to mention a couple of things that are definitely on my mind during this watch and wait time frame. So being more aware of some of the, I never like to say the positive things that have come about from a cancer diagnosis, because it always feels very uncomfortable to me to think about. It's not, unicorns and rainbows now that I've, come to terms with my cancer, but I have had to make very intentional choices at times, that some were good and some were, difficult things that I needed to decide as a result of being post-treatment and still aware of the potential for reoccurrence. So making the decision to start a family, knowing that I had a disease that was likely to recur at a time when Rituxan was only just really starting to be understood about how the benefits of that treatment were going to be. As I mentioned earlier, making a decision to leave the corporate world and start my own business. I'm a consultant. And making that choice, knowing I was leaving an employee health care plan, different forms of insurance that were available to me, was scary, but ultimately I made a decision to live a life that really mattered to me, and that included choosing to have kids. It included starting my own business. And even sort of wrapping my head around the survivor identity, and people hear that you're done treatment 6 years ago, so why are you even bringing it up anymore? Why are you still involved with Lymphoma Canada? That was a long time ago. And people really don't understand that this, for my kind of lymphoma, while it's been stable, thank goodness, for many years, it's still very front and center for me, because I know the likelihood of recurrence. I just don't know when. And so figuring out that balance between those different identities and then using those different, pieces of information to inform the life plans that I make. And really being mindful of building a life that is legacy-minded and making, today really count. So that kind of comes to the end of my section. I'm really mindful of time. I know we had to extend. This visual for me is really, the time of watch and wait is really to arm yourself with information, optimizing your health as best as you can, to prepare yourself to be as fit, both emotionally, mentally, physically, for that period of time. For someone like Margot, it's been years, which is amazing. And so, whatever that time frame is for those of you on the phone who are in watch and wait, trying to be as in optimal form for that point in time when it comes, you'll be in that much better readiness to, shift gears at that point. So if you have any questions, fire them in the chat. Otherwise, I will hand it over to Tanya and Mark.
Thank you, Alyssa. The strategies that really helped you cope with the watch and wait and treatment, and then moving back into a watch and wait mode are great strategies to help kind of deal with a chronic type of illness. And so my next step is I'm going to look at strategies for the future. And so my number one question that I get asked every day from patients who have leukemia and lymphoma is, what can I do? What can I do to prevent this from happening? What can I do to be as healthy as possible? What can I do to have this be delayed as long as possible to start treatment? And what I can tell you is that there's no evidence to suggest you can do anything from keeping this lymphoma quiet. But there is some evidence to say that if you can take care of yourself and live a healthy lifestyle, people do better. And so people who need treatment and are healthy and active and are not smoking, not drinking heavily, actually do better when they receive treatment compared to people who really are not taking care of themselves. So, it's very important to, maintain a healthy diet, have exercise, meaning at least 30 minutes of some type of activity, whether it's riding a bike, going for a walk, swimming, some type of cardio activity. If you do smoke, there's lots of programs out that are available for smoking cessation to help people quit. What we do know is that once anybody is diagnosed with a cancer, people are just more prone to developing secondary cancers. And by continuing to smoke, I use the term you're inviting trouble. So if that's one thing that you can do, certainly will improve your health in general. And when and if people need treatment, it's helpful as well. The other piece that I think is very important is looking at stress. And when people are very focused on their symptoms and waiting and watching, and you become in this kind of really is guiding your life, the stress can become quite overwhelming. And really kind of looking at some strategies and balance with family and work and life and yourself and your treatments is really important to try to reduce your stress as much as possible and enjoy your health. So we've talked about watch and wait. We've talked about why people do not need treatment. We've talked about when people need treatment. And so what I want to get across is that if, you've been put on a watch and wait, whether it's initial diagnosis or you've had treatment and you're back in that watch and wait program, you really need to know your body. Some new symptoms or changes in your lymph nodes that happen quickly, those may be reasons to contact your healthcare team. So people may develop a lymph node here and there, and it's okay. But if lymph nodes are changing quickly, so for example, you have a lymph node that's the size of a dime, and within a week or two, it's the size of a golf ball, that would be reason to give us a call. These B symptoms, so unexplained weight loss, unexplained fevers, significant tiredness or fatigue that has changed drastically, or even the symptom of generalized itching that is perseverant and just will not settle down, these are reasons to get a hold of us. Now, having said that, lymph nodes are part of your immune system, and they fight bacteria and they fight viruses. So the normal response for lymph nodes when someone's sick is to increase. They usually become tender. And then once they're done fighting or clearing the bacteria or the virus, they settle down. And so kind of getting to know what your normal is. So if you have a sore tooth and you develop a lymph node that's enlarged, well, that lymph node's working, and we're glad that it's working. As long as it settles down, then, that is a normal response. And so those are things to remember. People get throat infections, people get tooth abscesses, people even get eye infections, and the lymph nodes become large, but they do settle down. And so, sometimes the panic sets in that, oh, this lymphoma must be active, and you need to just kind of take a breath and think, well, what else is going on? What we know is that lymphoma is low grade, which means it grows slowly, and there is rarely a rush to start treatment quickly. So you have time on your hands. There's no, need to get into panic mode right away. You need to kind of reassess, what's going on in the family, other people sick, and whatnot. In time, you will get to know how your body responds to infections and become more confident in coping with small changes that often will go away. What I hope is that people think of watch and wait as a chance to really maximize your quality of life. This is your opportunity to take good care of yourselves and enjoy life rather than waiting for something to happen and treatment to begin. So I've listed here some resources that are specific to our area. First of all, our team. My assumption is that most people have a team that they can contact. And so contacting the physicians, the nurses, social workers, dietitians, there's a whole team that's working alongside patients to help people feel better. And then there's lots of resources that are available in the community. So in our area, Hope Spring, there's Wellspring, there's Lymphoma Canada, Canadian Cancer Society. And so I've just listed a few resources that, if you're looking for more information or you want to touch base with someone else that is going through the same experience, certainly lots of resources to help out.
Wow. Thank you so much, Marg, and thank you so much, Alyssa. Very, very informative presentations, not just from a clinical perspective, but also from just an experience perspective. So we really appreciate that. There are a few questions in the chat. I know we are running late on time, so if you have to leave, please don't feel guilty. We will have this session recorded and available on our website. And some people have also chatted privately to me, and I will bring those questions up as well. So Hertha, thank you for providing that resource as well. Lymphoma Survival, we hear from a lot of patients that that's an excellent resource for them. And I know, Joel, you asked a question and Alyssa answered that question. That was one that we'd also had chatted to us as well. Alyssa, there's a question for you here. When you're in watch and wait, do you feel like you're healthy? And if so, how do you address your situation with your children? And your friends, I think, would be something other people would ask too.
I'm not sure I understand the question. So you're saying because I'm feeling well right now, how do I answer the question about being in watch and wait?
No, I think that what the question's about really is that many people, when they finish treatment with other types of cancer, they finish their treatment and they're in remission, so they consider themselves cancer-free, and then they feel freer to talk about it. This is something I had. This is something that's finished. When you're in watch,
okay.
How do you address that with your children in terms of how do you explain your situation to them?
So, I've heard a lot of different things. I have actually heard people with follicular describe, consider themselves in remission. And, that's, certainly one approach that in their mind it's a phase that's ended. And so, but for myself, I've been, I have lots of conversations with my hematologist, and certainly he describes it as that my disease is stable, and so those are the words. I mean, my kids are still kind of little. Lymphoma is a word that they've always heard, and we talk about it, and they know why I'm involved with Lymphoma Canada and all those sorts of things. They've asked me, are you going to need treatment again? And what I've said to them is, there's definitely a likelihood or a possibility with my cancer and with other kinds of cancers that it can come back. And this is why I go to see my cancer doctor, twice a year to get checked out, so that if it does come back and when that happens, that we're ready to start treatment then. So we're keeping a really close eye on it. And in the meantime, that's why, I eat all these vegetables and make you eat all these vegetables. And, so.
That's great.
Yeah.
That's great. That sounds like, I love the that way of talking about it, that your disease is stable. That's great. I haven't heard that before.
Yeah, that's usually the word I use a lot. And so sometimes people will ask me, tell me more about that. That's not a word I've heard before. And that sort of opens the door for a little more detailed conversation. I know with other people, what they're hearing is, I'm in remission. Like that's right. They hear stable, and I know that they're interpreting that as you must be in remission. And, I just leave it at that.
That's great. Okay, actually, I think I'll ask Marg to address that as well, the issue or the difference between being in remission, watch and wait, that kind of thing. How do you address that with your patients?
We use different words for the same thing. We seem to like that. So, I'll use the word remission. I've used the word quiet. I've used the word stable. And really our approach is watching and waiting, or surveillance, right? And so one word is to describe what's happening in the body, and then the other word is really talking about how we're going to manage your plan of care, right? So watching, waiting, surveillance, follow-up, they all really mean the same.
Oh, that's great. Thank you, Marg. That's great. That helps clarify too. Watch and wait or active surveillance is the method of treatment or the protocol, and remission or quiet or stable is what's happening with your disease. Mm-hmm. Marg, there was a question earlier in the chat that we said we would address. I know Alyssa talked about it a little bit. It was a question from Margot, and Margot asked, really in the stage that she was diagnosed in, she's now been in watch and wait for 5 years. So what is the question? I'm just going back to it. What is the usual length of time of watch and wait?
So that's a great question. And, when we look at statistics, not one person is a statistic. So what we do is we collect data and then we average out numbers. And last I read, for people who are diagnosed with a low-grade lymphoma, and the average of when people need to start treatment is about 1.5 years. Having said that, some people need treatment up front, and some people it's been, more than 10 years and have never needed treatment. So, it's very hard to put a number on the watch and wait piece. Once people have treatment, so say people have been treated with CVP-R or bendamustine-R, then we have another statistic that will say, well, we expect your disease to be in a remission for, say, maybe 4.5, 5 years. And then, again, it's a statistic, right? So some people may relapse while they're on treatment. Some people it may be 10 years before they need treatment again. So lymphoma is very individualized.
That's true. So we have another question here from Sam, and Sam has asked, on the holistic side, is there any information on the efficacy of green tea? And before I turn that over to Marg, I'm just going to mention that coming up in December, we actually have a webinar, another webinar, which hopefully we'll have a little bit easier technological experience with, that's all about complementary approaches to managing lymphoma. And so that might be something that expert, Dr. Linda Balneves, who will be on that webinar, will be able to discuss. Marg, do you have any thoughts on that?
I don't have any data to support whether green tea is helpful in lymphoma. I know I was at a complementary medicine talk, and there was talk about using different types of green tea and that they help people with overall benefit, not specific to lymphoma, but just general health. The only thing I can recall from that meeting was that it was all about Sri Lankan green tea, but why that is, I don't know. So I will leave that to the experts regarding the green tea. But I don't think that there's any harm in green tea with lymphoma.
Yeah, there's a lot of new discussions around complementary medicines and approaches, and some of those things are things that we used to ignore because they weren't traditional, but or mainstream, and so now we know that there's some things that have value that are important to understand, but it's also important to know how to do your research and how to have that conversation with your healthcare practitioner as well. So that's why we're doing that webinar in December. If you go to our website, you can see the date. I believe it is on December the 10th. So anybody else? I don't see any other questions in the chat that are public. And the one question that came to us privately for you, Marg, is there anything at all that people can be doing with their family doctors when they're in watch and wait? Should their family doctor be doing any monitoring, or do you leave that to the cancer centers?
So we certainly like to work with our family practitioners, and they certainly want to be involved in people's care. In general, looking at family doctors, to go see your family doctor about lymphoma, they can certainly start. We get lots of messages from family doctors saying, I saw so-and-so, I'm not really clear, do you need to see this person based on their symptom? So I don't think it's important to continue on your relationship with your family doctor. One other aspect that's really important is that we know that once people are diagnosed with a cancer, for some reason, the other screening that's required, people seem to put that on a back burner. So, screening for breast cancer, screening for cervical cancer, screening for colon cancer. Those are all very important to keep up with.
Right. We have a question from Carrie about flu shots. How do you address flu shots?
So in general, what we say with flu shots is at our center, we recommend them as long as you haven't had any allergies to flu shots. In general, as long as any type of vaccine is not live, then they're fine. If one has a live vaccine, then that conversation needs to be held with the oncologist or myself, a nurse practitioner. So specifically, we get lots of questions regarding the shingles vaccine, and that is a live virus. So that's a discussion that needs to happen with your cancer team.
Right. Okay. Well, that's been a great discussion, great answers to the questions, everybody, and great questions as well. So we want to thank all of you who were able to bear with our little glitches, for persevering and joining us on the webinar. As we've mentioned, this webinar will be available on our website in about 2 days, so please check back. It will be under the resources section of our webinar. And to Alyssa and Marg Meyer, thank you so much for your expertise, both your clinical expertise, your professional expertise, and your experiential expertise. It's really invaluable for all of our patients and their family members. So thank you very much, and thanks everybody for attending.